My talk is very simple. We're talking about the most common endocrine problem in women by far. I took this slide because I thought it said the Dietitians Guide, and I thought it was very appropriate because most of our PCOS patients pretty much deal around the issues of weight, and that weight kind of predicts any possible outcome they'll have, whether being good or bad, from the reproductive point of view and the long-term outcomes from the PCOS. So I thought that the title itself was very appropriate if you look at that point of view. So I just wanted to share this slide. Say, if you look at the challenges with PCOS, I had an opportunity to look at the previous Part 2 exam paper that was talking about, the question was on ovulation induction in a polycystic ovarian syndrome patient. And when I look at the question, I thought it was going to be an aced question and aced answers that I'll get. But I was very surprised and very demoralized on the answers we get, because this is a very common condition that we see, that we discuss every day in the clinics. So if you look at the challenges around women PCOS, you can literally look at it from when they are young, as an adolescent, and then you look at them during their reproductive age, when they are trying to build their families, and then over and above, when they grow older, what challenges are they going to face from the disorder itself? So, and thing that I must say we tend to ignore often with the polycystic ovaries is the issues of psychological impact, what the PCOS have on these women. Sorry about the small slides. So I thought the objective of this talk, if we can be able to be comfortable how we make a diagnosis and how you can formulate a comprehensive management plan for the patient the time they see you at that particular time and going forward in the future, what advice can you give them? Then we have achieved the purpose of this talk. Now, if you look at the outline of the talk, yes, I would like to look at the diagnosis criteria, the pathophysiology very briefly, investigations that we use, and often how can you be effective in terms of cost-containing measures when you evaluate a patient with PCOS, because you can really be at lab, do everything without any goal in mind, but you can do focused investigations for that particular period, trying to target your management plan. If you look at diagnosis of PCOS, I think it's very standard that we accept the Rotterdam classification. And if you look at the background criteria, we initially used the NIH, National Institute of Health, diagnostic criteria, which looked at all features that we know: chronic anovulation, hyperandrogenism, and then of course polycystic ovaries. But there were additions to that, looking at other endocrine pathology that could be associated with hirsutism, associated with obesity. So it was very, very intensive, and it wasn't really streamlined to day-to-day use in the clinics. And then we look at Rotterdam, that narrowed things down, and I won't go into detail because that's what we use every day in the clinic. Rotterdam is 2 out of 3. Chronic anovulation presenting with menstrual disorders in terms of oligoamenorrhea. And then, of course, the issues around hyperandrogenism, either being clinical or biochemical, you can confirm that on a blood evaluation. And then, of course, the ultrasound features of polycystic ovaries. So I thought I won't go into details, just to try and bring to understanding where are we, what we used to do before in terms of diagnosis. We use Rotterdam currently, and I must say recently there was a lot of debate on whether the Androgen Access Society wanted to take over the definition of how you diagnose PCOS. But I think that debate and controversy is fading away, because they were more paying attention on androgen production, androgen clinical presentation, and more so ignoring the other related features with polycystic ovarian syndrome. And I often say we had some controversies around polycystic ovarian syndrome. One is where you have polycystic ovaries and the individual do have regular cycles and hyperandrogenism. So you'll always have this mixed bag in terms of androgen excess and how does menstrual influence or get affected by that disorder. And you look at polycystic ovaries patient with irregular cycles without hyperandrogenism, and then you'll have a group where there's polycystic ovaries with no overt symptoms of either PCOS or any other. But these are all variables that you'll get in this individual patient. But to make a diagnosis, then you'll need a Rotterdam to say. But you cannot have this mixed bag in defining polycystic ovarian syndrome. You can define individual characteristic patients in those categories that they may present with. So if you look at the pathophysiology, I'm sorry if this slide is not quite visible, but I'll just summarize where the red bullets are. If you look at the middle here, I always say it's always a story of a chicken and a hen. Which one comes first? Does the hen lays the egg first, or the egg comes and then the chicken will come later? So you never know when to start. Where do you isolate the problem with polycystic ovaries in terms of the pathophysiology? And there's always been a belief that it pivots around hyperinsulinemia. That you get this patient, they're hyperinsulinemic, and they are going to drive their pituitary's hypersecretion of LH. And that LH is the one that drives your androgen production from the ovaries, and hence excess production of androgens. But on the other hand, you can always argue that the problem starts with the ovaries itself, that hyperandrogenism itself could be the one that flares hyperinsulinemia, if you look at the other literature. So you can always go back to and forth from here. But the key to that is that hyperinsulinemia, hypersecretion of LH that you get, that drive the production of androgens. And then, of course, there's always another potential definition or argument that the primary source is hyperandrogenism, not necessarily from the ovaries alone, but you may argue from the adrenal gland itself, where you have excess production of DHEA, and that's going to drive the whole production of androgens, and then that having an impact on the ovarian function as a whole. So the same author proposed another theory that's it's not necessarily around the issues of hyperinsulinemia alone, where you drive or you initiate the process in the polycystic ovarian dysfunction, but it might actually be around the ACTH or the cortisol at the periphery, where you have an abnormal metabolism, that you have excess cortisol metabolism or increased, and that's going to influence your ACTH production in the pituitary. And then, of course, you have excess androgens, and they define that in collaboration with PCOS. So you get all these theories going back and forth. Is it the hyperandrogenism that initiates the process? Is it hyperinsulinemia, or is it excessive production of your LH that drives the whole process? To make yourself comfortable, it can go either way, but you were able to synchronize all these theories together. Hyperinsulinemia, then it drives the pituitary to drive your LH, then you drive your androgen production. And you can always pivot around the triangle in that way. That will make life very easy, but you can never find a solid evidence promoting one theory over the other as to where the primary source comes from with PCOS. And then when coming to investigations, as I said, the investigations, you probably have to look around where the problem is. This is a slide I showed you before. And say, if you look in young women, so the young reproductive age, the main concern that they will come to see you, one is menstrual disorders. They will come with the issues of androgen production where they are hirsute clinically. And then, of course, the infertility issues. So you can look in that way and say, when would I see a patient with PCOS? Primarily when they are young, it's issues around menstrual irregularities, hirsutism, and then, of course, fertility issues. Contraception, not so much. And sexual health, for me, I think it's all around there. The way they perceive themselves, the way they feel about themselves, how they're going to influence their sexual behavior. And strange enough, there was a TV clip that came to visit us. I can't remember the documentary called Zescon or something. And the lady who was from the documentary, they are from somewhere in the middle of Cape Town. She's a PCOS sufferer herself. So she came to us to inquire about PCOS, how do we diagnose PCOS, how do we manage this patient. And as we were talking, then she started crying and put the camera on the side and said, no, she has been battling with this thing for so many years. She hailed all the way from the Transkei. In the Transkei, if you don't menstruate, you either bewitched or that menstrual blood is going to clot your brain and then you're going to be psychotic and all that. So she had all this stigma being labeled on her, purely on the basis of PCOS. So there's a whole lot of psychological impact that PCOS have on this patient, and that we tend to ignore. We pay attention to the menstruation, pay attention to the fertility profile, but psychologically we close that window and then we never pay attention there. And then, of course, everyone ages unless you die before you get to the age that you want to be. Then, of course, you're going to deal with the long-term complications of polycystic ovarian syndrome, and particularly metabolic syndrome. And that will always be around the issue of weight. Then you start talking about diabetes and ischemic cardiovascular accident. The cancer risk, it's a question mark, because there isn't quite a good evidence that if you have PCOS, it's a risk factor. And I say independent risk factor for endometrial cancer and ovarian cancer, as has been suggested or potentially thought to be. And you can see at the bottom, the people who will be involved in the care of these women. It can be from the pediatrician up to the geriatric physician. So you can choose in your lifespan who you're going to choose, unless that condition chooses for you. So in terms of investigation on your right box there, primarily we do the androgen levels, testosterone, sex hormone binding globulin. Then you can calculate your free androgen index. And then, of course, the FSH and LH is what the literature suggests. I really suggest that in our clinic, under resource-restricted setting, FSH, LH is not going to influence your management anyhow. So we don't do LH and FSH routinely in patients with PCOS. It's not going to change how you made a diagnosis. It's not going to change how you manage the patient in overall impression. And the AMH equally so. We don't do AMH routinely. But I would say when you look at your subspecialist level, this might be an issue of debate, because it's becoming a lot of topical issue. How can you use an AMH to predict or to make a diagnosis of patients that will have polycystic ovary syndrome before they become clinically symptomatic? And then, of course, how are you going to use it in your reproductive evaluation of those patients? Because we know PCOS patients are at risk of hyperstimulation syndrome. How are you going to use AMH as an independent variable to predict those that will have hyperstimulation syndrome? So I would say AMH in inverted commas if you're going to use it at your certain level, but not as a primary test or a parameter for PCOS. So at our level, in our practical purpose, I say yes, we do the androgen levels to document and to confirm. And then, of course, the prolactin and thyroid function tests, I think those are basic, especially when they come with the menstrual irregularities. And you want to do that as a baseline, of course. The ultrasound to confirm the polycystic ovaries. And then, of course, if you're dealing with an obese patient with hyperacanthosis nigricans, you have that evidence of hyperinsulinism, then you can argue on the issue of GTT and the lipid profile, that I have a patient with metabolic syndrome and I want to plan her treatment going forward. But routinely in a lean patient, I don't think you'll be justified to do GTT and the lipid profile. And then, of course, if they come to see with infertility issues, the semen analysis, tubal patency, the purpose of the talk is not to talk about infertility. But I'll just say, if you have a polycystic ovarian syndrome, we accept and we, as a fact, or assume that they are infertile because they are anovulatory. And within good clinical practice, you can manage that patient for anovulation. And if they do not conceive, given a period of time, then you can go spend some time on doing those tests, because you'll accept that 15% of those patients might have a tubal or male factor problem, not necessarily that they are anovulatory. But I think it will be justified and within good practice and limiting your resources to your, margin, to treat anovulation first before you venture into other possible causes of infection. So I don't think you'll be crucified if you say, I'm not going to do tubal assessment test, semen analysis. If you made a diagnosis of PCOS, they're infertile, you can say, let's correct this first, and then you can look at the other issues later. So if you look at a targeted approach, or in terms of treatment, I think lifestyle modification is at the center of everything. And that is pretty much look at the way, I'm not going to discriminate here as it was discussed, but the obesity issue, it becomes a major problem. And this takes me back, I remember Vincent Muleleko was an initial fellow who Gerard fought for him. And when Vincent arrived in Cape Town, he was very disgruntled. He came from the personal point of view, he was hypertensive, and he was controlled on diet all these years. He trained in Ireland, he was happy, and then he came to Cape Town. Within 6 months, he came to my office and he said he's very concerned. I thought he's leaving. I said, what is the problem? He said, no, he had to study antihypertensive because the blood pressure is no longer controlling on diet. I said, maybe it's Cape Town that is flaring your hypertension. But nonetheless, he says, no, he doesn't think it's the hypertension. He thinks it's the Monday clinic when he sees the PCOS patient. And to a point where he made an effort, he developed what do you call it, aerobics class. I don't think he's physically or exercise inclined, but that was driving him mad. He went to develop an exercise class, and he had classes in Peru. One Saturday he went there, he was alone. The following week he went, there was 2 of them, but the second patient, it was the husband of the patient. It was not the patient. So he gave up. So it simply tells you that obesity is a major problem with polycystic ovarian syndrome. And we have to accept these patients are very somehow hopeless, or they gave up on the hope that no, one day they'll eventually lose this amount of fat and then make something out of themselves. And having said that, with the weight management, there are a whole lot of suggestions that will come around the drugs and all that, which I have so many stories that I can tell about overweight and drugs to try to cut corners and get to the point very quickly, but it never works. So if you look at the weight loss in PCOS, as we often say, lifestyle modification, I'll bring to your attention that if you look at the amount of weight that you need to lose and the influence or the benefits of that weight loss, it's very significant. I mean, you look at spontaneous pregnancies at 18 months, if you can lose the recommended weight, if you look at the control group, and then this is an interventional group, where people have lost at least 4.7 kilograms, in the control there was very minimal loss in terms of weight. The pregnancy rate is quite significant, very significant after 18 months of that weight loss, that things just happened on their own without any intervention from the medical fraternity. The miscarriage rates, high miscarriage rates in the control group, although not significant. Your pregnancies following any form of assisted reproduction, very impressive. And over and above your spontaneous pregnancy. It's an old paper, but it's just fundamental findings that you'll get. And that hasn't changed up until today. And then you look at the weight loss in general with PCOS, and we say if you can lose 5 to 10% of your body weight, that will translate to at least 30% reduction in your visceral fat. And the benefits of that, as I showed you in the previous slide, on your aim of gaining that pregnancy results, it's immense and impressive. Your metabolic and endocrine profile will improve significantly, and then of course your reproductive function will make some impressive roads as well. The question is, what diet would you recommend this patient from? And I came to be honest and frank with the patient and say, no, even if somebody have to tell me that I must go on a diet, it will be a very difficult task to do. One, the foods that are suggested are very expensive. I cannot afford to buy a fresh fruit every day unless you're going to plant. So you can be not necessarily be prescriptive to the patient, but suggest and share opinion. If they can plant their own vegetables, even better. If they can drink water, it will even be much better. But this patient, they believe in things like Coke and Coke diet, Coke Zero, you name them. At the end of the day, they are all sugar. So what I talk to the patient and say, no, I'm happy you can eat whatever you want to eat, but limit what you eat. If you wake up with a bottle of water in the morning, that is better. If you can eat half of what you used to eat, that would be excellent. If you walk half a day, half an hour in a day, see how things are going to change, building forward. But for you to go, me to tell them you must eat this, don't eat that, don't do that, then that never works. That never works at all. And at night, if you think you want to nibble on something, just switch the TV off and run away to bed and sleep, because that will save you. Because that's the time that they want to eat when they're watching the television. But I think being prescriptive to this patient what diet to take is often more detrimental than being helpful to them. And then, of course, there are strategies that you can adopt. So if I go on a diet, whether it's a carbohydrate-restricted diet or high-protein diet, it's all no evidence that one diet is superior over the other. So you may suggest whatever diet they're comfortable with as long as they keep it to the limit, and that should suffice. If you look at the strategies in terms of all the form of medical treatment, we say if your BMI, it's certainly, you are obese, BMI of about 35, those patients you may recommend or discuss the medical therapy with them. But it has to be in conjunction with a lifestyle modification and made it clear to them that it's not a quick fix, because that never worked. And this is where the wheels of the wagon fell off in our clinic as well. We used to have a dietitian, very committed dietitian, Anshen. Most of you know, Prof. remember Anshen. And then we received an email from Anshen. Anshen said, no, I'm not coming to that clinic anymore, I'm leaving. Everyone was shocked. What happened to Anshen now? And then only come up later that frustration that built from Vincent when he developed an exercise group, the exercise never materialized, his blood pressure went up. Then he started prescribing Duromine to the PCOS patient. And that threw Anshen over the roof. Let's say, I'm trying to work with these people on diet and you're busy giving them the tablets on the other hand. So you have to discuss it in harmony and harmonize the whole thing, but you tell the patient that yes, medical treatment is not a quick fix, but the obese patient with high BMIs where you've tried diet and it didn't work, you may certainly suggest some of this treatment, medical treatment. And we're quite comfortable with Olisted. Olisted is a appetite suppressant. It doesn't increase your BMR. It doesn't have any impact on your heart rate. So it's a very safe drug to use. And then, of course, those who are morbidly obese, then you may suggest bariatric surgery, which it is in the literature that, yes, it might be of benefit for these patients. And then, of course, you avoid all these measures, either being excessive or intense exercise or weight loss in an extreme form, medical treatment or being bariatric surgery, if they are in a treatment cycle. So you can do all this outside the cycle when they are in treatment, then they can't do all these measures at the same time. And then, of course, if once you move from lifestyle, then you aim to induce ovulation. This is where the basis of the discussion will start. That for you to get those eggs, we don't want the free-range eggs, but good quality eggs. Ovulation induction for patients with polycystic ovarian syndrome, our primary drug of choice is clomiphene citrate. It's very cheap, it's well studied, side effects are there, but at a higher dose. At the lower dose, you shouldn't experience much of the side effects from clomiphene citrate. Then the option came with the aromatase inhibitors and then the gonadotrophins. Then we'll talk about all those. If you look at clomiphene citrate, and I'll say these things briefly in one line that you're comfortable to use clomiphene citrate. As to when you start it, evidence does not support the specific day. It can be on the day 2, but at most day 5. We can't start later than day 5. So whether you start on a day 2 or up to day 5, there is no evidence that starting in any other day is better than the other. And then, of course, the starting dose, we say 50 milligram. The 25 milligram dose does not work for polycystic ovarian syndrome. So you start at a 50 milligram dose and you can rise by 50 milligram. But I'll say it with a caution, the minute you give them 100 milligram or above 100 milligram, or 100 milligram to be specific and above, and you recommend home plan, just be prepared that you will have a very high percentage of those patients coming back without any pregnancy results. Because the 100 milligram dose, now you're going to start to tamper with your endometrium. You're going to tamper with your mucus. So the so-called clomiphene failure will be very high. So you'll achieve ovulation induction, but they won't fall pregnant because of the side effects from clomiphene citrate. So just be careful that if the minute you're going to step up the dose from 50 milligram in a PCOS home plan treatment, that your results are going to be very detrimental. So if you go 100 milligram, you may actually suggest an artificial insemination. Then you're going to mitigate the whole mucus issues around the clomiphene citrate itself. And the question that if the patient does not have a period, yes, Kharar?
I just want to say, so if you have an adequate lining, can you then assume that the mucus will not be an issue?
You cannot assume that, unfortunately. You cannot assume it because the endometrial line itself is not a surrogate marker to tell you what's happening with the mucus. You rather do a post-mucus test yourself and see whether it's not affected at that dose and you're comfortable to continue on that line. Yeah. And the other question is, if you have this amenorrheic patient, because often most patients with PCOS, they'll come without periods. Do you really have to induce a period before you give them clomiphene citrate? And the answer is no, you don't have to. You can give them clomid as long as you confirm she's not pregnant and you're happy to start on a day one and then, or the first of the month, say clomid on this day, I can monitor the cycle comfortably. It's okay. But often it's just for our feeling better that you've shared that endometrium and then you can start comfortably the cycle with the clomiphene citrate. But whether you have withdrawal bleed or no withdrawal bleed, as long as she's not pregnant, you may start clomid even without seeing a menstrual period. And the other thing, whether you need to monitor a cycle with clomiphene citrate in the PCOS patient, I think that is recommended, in my understanding. And when to stop, I think this might not necessarily be a fixed protocol or suggesting that, yes, you stop after 6 ovulatory cycles, You may stop after 12 if you're comfortable. And then, of course, when there's no ovulation at 150, by then you already know your back is against the wall. Or if your thickness is less than 7 millimeters. I don't think you can stop there. You can supplement or enhance that endometrium as long as you're achieving ovulation induction that you're aiming for. If you look at the outcomes of clomiphene citrate itself, look at all literature. These are all studies that you look for. But the ovulation rate, and these figures I put them there because they haven't changed. You're more likely going to achieve ovulation induction rate of around 70-75% with clomid, quite comfortably. And it's a cheap drug. I mean, 5 tablets of clomid will cost about 80 rands or 100 rands at most. So if you're going to achieve such ovulation rates, that's impressive. Your pregnancy rates around 30%. I think 40% is a bit high. You look around 30% pregnancy rates with clomid, and then the miscarriage rate around 20-25%. And then the definition that I said before, there is a difference between clomiphene resistance and clomiphene failure. We say the patient is clomiphene resistant if they are failing to ovulate on clomiphene citrate. If you're failing to build those follicles, then you can say, yes, at the maximum dose you fail to ovulate, then we say you are clomid resistant. But then you'll have a group of patients that do ovulate on clomiphene, but they never achieve a pregnancy. Then we say those are clomiphene failure patients. I hope that those definitions will make it easy for you. So even when you counsel the patient when you want to stop the clomiphene, for what particular reason, at least you are upfront and prescribe to them what you mean. The patient that you're most likely going to fail or be resistant from clomiphene, and this is the patient with free androgen index that is very high, increased BMI, increased LH, and then insulin. But often all those two are good enough to tell the patient that it's not going to work. And you can use the BMI from the beginning and tell the patient your BMI is very high, we're not going to do anything until you start losing weight. Without going to waste a lot of money looking at the LH and the free androgen index, the BMI alone can be an independent prognostic factor whether she's going to resist or not from clomiphene citrate. And the reason for clomiphene failure, as I said before, it's mainly an impact on the mucus and impact on the endometrium, but more so the high premature LH surge with this patient. And it can be very frustrating when you're dealing with a high body mass index with this patient because you're forever biting yourself for things that you don't have full control over most of the time. So the question of whether the metformin is going to be a benefit to a patient who have or who experience clomiphene resistance during your treatment. Yes, there is an argument that it improves reproductive function, it improves response to clomiphene citrate and gonadotrophin. These were the assumptions with any form of insulin sensitizers, including your inositol or your minor inositol. But this evidence is forever changing. But I'll give you the figures. If you look at this paper by Moll, this was 2006, it's almost 10 years ago. If you look at a group, on your left hand, or you look at your ovulation rates, your ongoing pregnancy rate, this means a fetal heart at 12 weeks of pregnancy, and then abortions, spontaneous abortions, not induced. If you look at clomiphene and metformin together, your ovulation is around 70%. You look at clomiphene and placebo, it's about 82%. Absolutely no difference. Now, you look at your pregnancy rates, 44, 52, no significant difference if you look at your confidence intervals there. So there's no difference whether you add metformin to clom. These are according to Moll at that time. And then you look at your miscarriage rates, equally so. So you would argue that then what is the benefit of adding metformin to somebody who's clomiphene resistant if it's not going to offer you any benefit in terms of ovulation, ongoing pregnancy rates, and this miscarriages? And then you look at this paper by Legro. This was a very good paper. I think it was a randomized trial that Legro looked at it. It was a where he looked at clomiphene and or metformin alone or in combination. The conception and ovulation rates, 39% with clomid, metformin, dismal. So we could never propose metformin alone as an agent to induce ovulation. No. So you could employ lifestyle modification and encourage them to change their diet, exercise. If they lose weight, they start menstruating on their own. If they don't fall pregnant, go on to clomid and see if they can fall pregnant. And clomiphene and metformin in combination, 46%. Slightly higher conception rates and ovulation rates. Miscarriage rates, absolutely no difference between clomid and clomiphene and metformin, but very high miscarriage rates with metformin, which didn't make sense to me at that particular time. Why? If you look at your live birth rates with clomid, almost 22%, and 26% with clomid and metformin, no significant difference. And therefore, Lego concluded that yes, clomiphene citrate is superior to metformin, and that was evidence. And in combination confers no additional benefit. In terms of your live birth rates, there was absolutely no additional benefit in adding metformin. And I think the importance of that, we're very easy as doctors to prescribe tablets. The question is, how much does this patient cost, or how much does it cost for metformin? The side effects that they have to tolerate from metformin alone when they are on this treatment. And you look at this insulin sensitizers statement from the ESRM and the ESHRE, it was 2000, they say there's no clear role of metformin in the management of unovulating infertility, either alone or in combination. There is no evidence in improvement of your pregnancy outcome, particularly your live birth, which is what matters at this point in time. So we're left to say, no, if we are clomiphene resistant, do we add metformin? And the evidence says, no, it doesn't add any benefit. And people started to say, okay, maybe if they are obese, it might have a benefit. If they are insulin resistant, it might have benefit. And then this was a meta-analysis, I think, yes, and a systematic review of randomized controlled trial. It was by Palomba. They look at metformin and gonadotrophins, which I think it might not have been a fair paper to look at, because gonadotrophins on its own, they are potent enough to give you that outcome you're looking for. So whether metformin was a good variable to add here, I don't think it was a fair evaluation. But nonetheless, the paper was published, and their finding was as such that if you look at live birth rates, and then they say it favored metformin, that you had more live birth rates in gonadotrophins together with metformin. But as I said, whether it's a metformin effect or it was gonadotrophin, but this was the finding of their randomized their review and the meta-analysis. And if you look at the pregnancy rates, favored metformin. So their argument was, if you have a PCOS patient that you're going to induce the gonadotrophins, if you add metformin, it's going to improve your overall live birth rates and your clinical pregnancy rates. In summary, when we talk about metformin, I say metformin before and during IVF or women with PCOS, there is no evidence that metformin will improve your live birth rates, that's for sure. But what we know recently is that yes, and there's more evidence to say metformin patients will have lower incidences of ovarian hyperstimulation syndrome. So it might be a very influential or a perfect strategy to reduce OHSS by giving a patient with PCOS metformin while you're going to induce them for IVF or for ICSI cycle. And this was a paper by Ichno and Maria. They looked at metformin in a primary ovulation as a primary ovulation induction in patients with PCOS, and this study was conducted at Tigerberg. And I just summarized their findings quickly here, that if you look at live birth rates, when you're comparing clomiphene citrate alone with metformin, this is the same findings that were found by Moll. Say yes, clomiphene alone is superior than metformin. That we knew. Nothing has changed from the evidence. Sorry. And then when they look at metformin plus clomiphene citrate versus clomiphene citrate alone, no difference. So you had more evidence showing that yes, whether you add metformin to clomiphene citrate to improve your live birth rates, nothing has changed from the previous studies that we know up to this study. And then they looked at individual subcategories and say, if you use metformin and clomiphene citrate as a combination versus clomiphene citrate alone for ovulation, they say yes, for ovulation purposes, it might have favored addition of metformin. This was a new findings from the previous study. And then of course they look at in obese women, BMI above 25, they say yes, adding clomiphene and metformin to clomiphene citrate, it might improve your ovulation rates. So this paper, different from the previous paper by Moll, is that yes, they did find some improvement in your ovulation rate when you add metformin in obese patients in that regard. And then another review by Miso followed. This was in 2013. Look at metformin versus clomiphene citrate for infertility in non-obese patients. And this we say the obese naive patient. That's the term they use. And the evidence they found that there was absolutely no significant difference in the two groups. They looked at one in the first group where they used metformin, clomiphene citrate. Is there any evidence favors clomiphene, favors metformin? None whatsoever. This is a non-obese patients. So if you look at the second group, they look at the pregnancy rates and the live births, and this is B being your live births here. No significant difference in your live births. So whether you're going to add metformin to a clomid in a lean patient to try and improve pregnancy rates or live birth rates, the evidence suggests no. And this was the summary or position statement from the Canadian guidelines. And this was 6 years ago as well. And I looked at if they've reviewed these guidelines. It's still the same. It hasn't been reviewed. And their conclusion was metformin combined with clomiphene citrate may increase ovulation rates. We agree. And potential pregnancy rates, but does not significantly improve your live birth rates over that of clomiphene citrate alone. So if cost is an issue to you, the side effects is an issue to the patient, then you may be comfortable not to add metformin to those patients, because overall it's not going to improve the outcomes. And then it leaves you disgruntled about everything and anything in life, from text to hate speech and everything. But nonetheless, if you look at the management, if you have somebody with polycystic ovaries, clomiphene resistant or clomiphene failure, the question is, can you add aromatase inhibitors, or you jump straight to gonadotropins, or you're going to offer them other strategies such as drilling? And I must say, in my opinion, and a little bit of evidence that we've had with aromatase inhibitors or letrozole, there hasn't been any remarkable change that you see in somebody who had clomiphene citrate failure or resistant in terms of your pregnancy outcome at the end of the day. You might have some improvement in 10 to 20% with aromatase inhibitors, but overall pregnancy rates, I haven't seen any remarkable difference. And the benefits being proposed that it does not affect your endometrium, and two, it does not affect your mucus. The concern with the aromatase inhibitors, it was the issue of congenital anomalies on the baby, particularly the cardiac abnormalities that were being proposed as the concern. But if you look at these papers, aromatase inhibitors for PCOS, and they looked at aromatase versus clomid, in terms of superiority trial or equivalence trial, it wasn't anything inferior They did a trial with the aim to prove that aromatase inhibitors are either equivalent to clomiphene or superior to clomiphene. They didn't go there with an intention that they could be somehow inferior to clomiphene citrate. And if you look at the outcome, yes, clomiphene citrate 100 versus letrozole 2.5. And you think in your head, knowing that at 100 you're going to blow that endometrium, and the endometrium is like giving an unfair advantage over the other. With the letrozole, they start low at 2.5. They can say the costs are less, the pregnancy rates are better. So I don't think it was a fair judgment. If they said 50 clomid, 2.5 letrozole, yes, you could have a fair comparison between the two. And the outcome was as such that clomiphene 100, letrozole 5 on this other study, and the pregnancy rates were 17.5, or say 18% with clomid and 15% with letrozole. So clomid still came tops, nonetheless. And then you look at this meta-analysis by Polizos. This was published 2008. 4 randomized controlled trials were included in that analysis. And there was a clear superiority of aromatase inhibitors in pregnancy rates, almost 20% increase, and deliveries 24%, 2.4. So you will argue that the evidence was always changing. You have individual studies not proving that aromatase are better than clomid, and this meta-analysis convinced everyone that aromatase inhibitors are better when you compare them with clomid. And this is the Canadian Tulandi. He looked at the outcome of letrozole versus clomid in almost 1,000 newborns. And this was to address the issue of congenital anomalies that was plugged against the aromatase inhibitors. In pregnancies, 397 clomid, 514. Anomalies, no difference between the two. And this was just to put the story to rest, that you will not experience any higher incidence of congenital anomalies with aromatase inhibitors. And this was looking at individual anomalies, and there was no difference between the two, clomid and letrozole. And then this was aromatase for PCOS. This was a review by Miso again. And just to summarize, if you look at looking at ovulation rates per patient, favors letrozole. If you look at the ovulation rates per cycle of treatment, there was no significant difference between the two. So you will argue that it means aromatase inhibitors might be of benefit to a certain group of individual patients. But if you look at the whole spectrum of patients in terms of cycles of treatment, it might not offer you any benefit. And therefore, you'll have to make that call. If you're going to counsel a patient who have clomiphene resistant, are you going to jump to letrozole? You have to be able to tell a patient it might not benefit you, given the evidence that yes, it's only beneficial in certain group of patients, and give them the figures. If you look at the clinical pregnancy rates, slightly favors letrozole. If you look at the live birth rates, no significant difference, because your diamond certainly crossed the midline. So there was no significant difference in terms of live birth rates. So if you look at the overall conclusion, you can say yes, letrozole might improve your ovulation rates in individual patients. You have to select which patients will benefit. In terms of cycles, it doesn't have any effect. In terms of live birth rates, there's no improvement. Therefore, how do you summarize your algorithm there from there? First line, lifestyle modification. Clomiphene citrate, if it fails, you may consider metformin, but just know that it's not going to improve your live birth rates. If you fail in there, then you may consider in a certain group of patients a letrozole or aromatase inhibitors. Other than that, you might just switch from clomiphene-resistant metformin to gonadotrophins if you're not interested in the letrozole group. I'm going to skip this slide. And this one, I think, Kharar, I'm going over your time quite badly. So I'll just go straight to gonadotrophins. If you're going to use gonadotrophins for PCOS and home plan, you're not planning IVF or anything. So the recommended approach is probably safer to go the step-up approach. The low-dose step-up approach, even better. The step-down is not well recommended for PCOS. And this how the two differs. Your low dose step up, you start with a 50 or 75 units of gonadotrophins, and this I think can be done by generalists quite comfortably, because in general people are very get scared to use gonadotrophins. But you can certainly use or prescribe gonadotropins as long as you know when and how, especially with the PCOS patient. You can cut down a lot of unnecessary referrals. So if you're going to give them low dose for at least 14 days and be patient with that patient, because you might only see changes, those follicles, say around cycle day 22 or 21. So you can't expect to see a follicle around day 14 or... Okay, I think I've talked a lot. You see, when the eyes are dying, then you know. So say day 14, at least you stay that low. Then you can start stepping up from day 14 to about higher dose, 75. And I'll say stay to 75, never go to 112, because then you're more likely going to run into trouble somewhere there. And after another 7 days, then you go up a little bit to about 100. So you can stay that low quite patiently until you see a follicle developing. Remember, you're aiming for monocular development. You don't want multiple bags, because once you run into that problem, then you either have to convert to IVF cycle or you have to cancel. And it's a waste of money to the patient. And if you get a low dose in terms of your pregnancy rates, you're looking around ovulation rates of 71%, which is very good. Fecundation of 23% is not even better than Clomid, but at least you reach some milestone, because those patients were failing with Clomid. Multiple pregnancies, that's 5%. I don't think it's very scary, but it's very high nonetheless. I'm going to skip this. This is a step-down approach. You just start high and then you go down, and I say this is not recommended for PCOS. And if you conclude, you say step up is much safer and more efficient than step down, for obvious reasons. You're going to avoid hyperstimulation syndrome. You aim for monofollicular development with a step up. And then if you look at your gonadotropins, that's no-brainer that yes, the gonadotropins will give you higher pregnancy rates than clomiphene citrate, either in the first, the second, or even in the third cycle. What I wanted to discourage is the ovarian drilling at lab. The question is, if you fail with the clomiphene citrate, or you fail with whether you go with gonadotropins or with ovarian drilling, the advantage that you can propose in your answer is that yes, drilling, you'll avoid multiple pregnancies, you'll avoid hyperstimulation syndrome, it might not be costly for the patient. As opposed to gonadotropins with the side effects of being cost of the treatment, and then the risk of hyperstimulation, the risk of multiple pregnancies, which you'll avoid with drilling. But drilling done without any idea can be very detrimental. The concern with the ovarian drilling is premature ovarian failure, because you bend more than you're supposed to bend, and then healing around that ovary encourages adhesions, and then it influences the tubes to undergo tubal occlusion. Therefore, you might actually precipitate the whole issue of secondary fertility than actually doing good. So there are concerns with drilling, but you can argue on the pros and the cons of each. And generally we say drill 4 holes. It's a 40 watts monopolar current that you use 4 seconds per hole. So it's a rule of 4. 4 holes, 40 watts, and you stay 4 seconds in each hole. And I just wanted to show you this video. This video is from one guy, Misra, the guy who I had a privilege to work with him. And
this is a simple laparoscopic.
listen, it's a simple operation. How many holes are drilled?
Drilling for the polycystic ovarian disease. This patient.
And I just tell you, the gentleman, he's not a gynecologist. He's a general surgeon. But in India, you can do anything as long as you know how. So he's a general surgeon. He does hysterectomies. He does whatever you call it.
And the primary infertility and clomiphene citrate and the other medical management has.
So we take the ovary. We often drill on the anti-mesosalpinx area. You don't want to go at the top close to the tube. So you go under the ovary, and therefore you can go ahead with your drilling. And as I said, it's a monopolar current.
So we are doing the ovarian drilling. Ultrasound has shown the polycystic ovarian disease, and here we will do only 6 to 8 drilling.
6 to 8
in the
drillings.
ovary. This is the tritone or PCOD needle. We are using the monopolar cutting current, and the only 40.
You see, once you've done that, you're done. So you wash the ovary, you irrigate, and then you come out. So he's going to proceed to other holes, but I'm not interested in you seeing the other holes, because all you need is 4 holes, 40 wards, 4 seconds per hole, then you just irrigate the ovary. Whether you drill 20 holes or 4 holes, the endocrine changes are going to be the same, but the detrimental effect is going to be higher with more holes. And it's very interesting that with just 4 holes, you'll be able to get the same effect as you used to get from Stephen Leventhal's period, where you do a wedge resection.
So basically this is a two-port surgery only. Third port has not been used in this case.
I'll stop the video because what Colin is asking, do you always do bilateral ovaries? Unilateral evidence shows that yes, you can do 1 ovary, you get the same benefit. But yes, we always do the 2 ovaries, back and back on the other, 4-4.
If the patient has a true polycystic ovarian syndrome, so now the right side and left side, both the side drilling has been completed.
So you can argue that now the ovary is nicely cooked. And so as I said, 4 holes, 40 wards, 4 seconds per hole, that's good enough to drill the ovary. And if you look at the evidence, looking at ovarian drilling versus gonadotrophins, at the top, your A, it's your live birth rates, equal outcomes, whether you drill or you do gonadotrophins. In terms of number B, your multiple pregnancies, definitely you will have fewer multiple pregnancies with ovarian drilling than with gonadotrophins. So that's the evidence you'll support, whatever modality you're going to choose, especially when you counsel the patient, am I going to give gonadotrophins or we're going to drill? And then, of course, in terms of assisted reproduction, it will often depend on the indication. Once you fail with Clomid, you fail with your metformin Clomid, and you're going to gonadotrophins, I think by then you start discussing with the patient gonadotrophins versus drilling, the pros and the cons of each. And then you can move to say, ultimately, we're now going to IVF, and now you can discuss the complications of ovulation induction in a PCOS from there. In summary, I think lifestyle modification still forms the basis and the standard form of treatment for PCOS patients. And I think in the long term, it's more beneficial and a lifestyle thing for them. I don't think we'll be justified to say, let's just see what will happen. You're well within your right to say no, go lose weight until you've lost weight. Only then we can start working with you. And that should be our policy in the clinic as well, to say, unless you lose some weight, madam, we're not going to do anything. From individual clinics, as long as she hasn't lost weight, don't even bother to refer her to Salima or to endocrine clinic. Ovulation induction, as we stated, have an algorithm. Lose weight, clomiphene, metformin. Then from there, whether you're going to use the aromatase inhibitors or gonadotrophins or drill, you can decide from there. And then that's the end of my talk. Thank you. Any questions on PCOS?
I have a question.
Yes.
When you gave a list of all the blood, you didn't include insulin, fasting insulin.
Yes.
So you don't routinely do it
No.
in a thin patient, but obviously if the patient's grossly overweight, then would you then do it?
I'll tell you why I didn't put the insulin there, Salima. There's a whole lot of debate when you have an obese patient with PCOS, whether you're going to do a whole HOMA spectrum, or you're going to look at only fasting glucose, fasting insulin glucose ratio. I think it will always be dependent on the individual units. But as I said, if you have an individual with clinical signs, hyperacanthosis nigricans, that you suspect hyperinsulinemia and insulin resistance, then you within reason to say, no, I want to know what's a fasting glucose or a fasting insulin. Because then you can always propose strategic management on how you want to deal with it, particularly coming to the metformin treatment and the long-term implications of that. But whether you're going to do fasting insulin or insulin glucose ratio, it always depends on individuals. But I don't think it should be used as a blanket initial evaluation for every PCOS patient, whether they are obese or non-obese. If you have clinical features, yes, use your resources that you have quite strategically. Yeah. Good, Gerard. If there are no questions, I'll